Good morning, good afternoon, and good evening, everyone. And thank you for joining us for this CanVector National Thrombosis Seminars. I'm Agnes Lee, and I'm going to be hosting today's seminar. I am very happy to be joined by two outstanding speakers, and we're going to hear about maternal health and VTE today. Just a bit of housekeeping before we get started. As some of you or all of you already know, this is a monthly seminar series that's been presented by CanVector, and we've had a number of seminars already with some outstanding speakers, and obviously we're continuing with that tradition with our speakers today. These seminars will be are video recorded and will be available online on the CanVector website. So you can certainly access this. And this is approved by the Royal College for Section 1 MOC certification. So I just want to give a shout out to the planning committee who has worked with me to plan these seminars, and Dr. Leslie Skeeth is one of our speakers today as well. So for today's presentation, like I said, we're going to be focusing on maternal health and VTE, and you're going to hear a fantastic lecture by Professor Patricia McGuire, who's going to be talking about investigating platelets in health and disease. And she will talk about some very innovative platforms that hopefully we will look forward to being able to use in healthcare delivery. And Dr. Leslie Skeeth is going to talk about postpartum thromboprophylaxis, giving a little bit of background about her pilot study called Partum. All right, and throughout the seminar, just to keep things moving, we're going to collect Q&As in the Q&A box. So most of you who are very familiar now, but by now I'm sure with Zoom, please put your questions in there, not in the chat box, because Q&A will be visible to everybody, and we will address all the questions at the very end, again, just to keep things moving. And certainly, Dr. Skeeth and Professor McGuire can certainly try to answer these during the seminars or during the presentations. We certainly should have enough time at the end to address it. So without further ado, I'm going to introduce Professor Patricia McGuire. Professor McGuire is an interdisciplinary a scientist. She is passionate about the intersection of artificial intelligence with biomedical science. She is a professor at the University College Dublin, or UCD, and the director of the UCD Institute for Discovery, which builds and cultivates interdisciplinary connections in the emerging areas of research themes through its visiting professor, Rising Star, and a Zoom for Thought programs. So really great innovative ideas. She is also the co-director of the translational UCD Conway Sphere Group, which uses unique tools to diagnose and understand a host of inflammatory-based diseases, including early onset preeclampsia, multiple sclerosis, and venous thromboembolism. And again, she's going to be talking to us about investigating platelets in health and disease. Professor McGuire, thank you very, very much. You're muted, still.
Now, thank you so much for that kind introduction, and thank you also so much for this wonderful opportunity to present the work of the Conway Sphere Research Group. I think I can control the slides. Yeah. Here we go. Okay, so the title of my talk today is Paladin, and we're going to use this Paladin platform. I'm going to tell you all about this and then use this platform to investigate health and disease. And this work is work that I carry out alongside my co-director, Professor Fionnuala Ní Fhionn, who's a consultant hematologist in 2 large hospitals here in Dublin. And about 5.5 years ago, we joined forces together to, so I'm a basic scientist, to basically understand inflammatory diseases that also obviously have the link between inflammation and thrombosis. So I'm a platelet biologist and have been interested in platelets for a long time. And recently, I'm very pleased to announce, we're also joined by a new co-director, who's Dr. Barry Cavan, who's also a consultant hematologist in one of the largest hospitals here in Dublin, the Maternal Hospital. So without further ado, let me tell you about our work. So I think everybody on this webinar today will understand that platelets have been widely known, obviously, to underlie hemostasis and thrombosis, and there's multiple diseases associated with this. But what's really intrigued me over the last number of years is all the other physiologic and pathologic conditions that have been involved in. For example, so the black font here is the physiologic conditions, and then the associated pathologic conditions here in red font. And really, these very wide responses then also underlie so many other different disorders. And for some reason, these are all coming up individually, but I'll just keep clicking. So, from cancer to aging, now platelets have been implicated in. And this fascinates me as a platelet biologist, and also as somebody who has very interested in, I suppose, what the platelets store inside them and what they release when they do clot. So this powerful cargo that platelets collect and also release out into the external environment. And a long time ago, it was my lab that coined the phrase, the platelet releasase. And this is what I really want to talk to you about today, this cargo that the platelet stores and releases upon activation. So just a very quick summary of this cargo. And I specialize a lot in proteomics. So I'm interested in the protein that's stored here, but also I should say that there's also that cargo also contains lipids and also RNA-based cargo. But something that I've studied really is the proteins. So, in this platelet releasase that's released out into the external environment once platelets are activated, they dramatically change their shape and are activated, is a powerful cargo. So you've specific mediators like VEGF, angiostatin, thrombospondin, TF4, RANTs. I mean, these are absolutely powerful mediators, and also powerful growth factors like PGGF, TGF beta. So a huge amount of powerful cargo that they're releasing out into the external environment once they're activated. And the interesting thing for me is something that I suppose was first published by Harry Heinen's group in the Netherlands in Blood in 1999, and that is about these small vesicular-like substances that are also stored and released from the platelet. So I want to just take a minute to bring you through what actually is present in this releasase. So obviously we have resting platelets here, and you activate them to dramatically change shape and release out their content of these preformed granules into the external environment. But when they do release out their contents, you can actually separate those contents really into three different portions. So this is obviously the soluble proteins, which I spoke about there, like platelet factor 4, thrombospondin, these soluble proteins, but also then there's these tiny, small, little extracellular vesicles that were traditionally known as exosomes, these tiny vesicles between 30 and probably about 150 nanometers, so really tiny. You could fit about 1,000 across one human hair, that small. And then we also, they're coming from the alpha granules, these small extracellular vesicles, but we also have large extracellular vesicles with these microparticles flab off the surface of the plate. And we're not the only people that have looked at these, but there's a huge amount, a wealth of literature on this platelet releasase. But we've looked, in our group, we looked from a protein perspective. So, I always show this, and I do some talks even to school children, and I always show this, what is the first thing you do when you cut yourself, a paper cut? And obviously I can't see you here, but I think the first thing everybody does is they lick their wound. And it's really interesting to me that actually it was only in 2015, I think the first paper came out, and then 2018, and this is from Rink Newland's group again in the Netherlands, showing that actually, we even have these small exosomes, these extracellular vesicles in our saliva, and actually they expose these small extracellular vesicles in our saliva actually have tissue factor on their surface, and actually this drives the wound, the clotting and the wound healing response when we lick our wounds. And one thing about this is conserved across the animal kingdom. This is almost an innate response. So this is fascinating that this is actually happening. And these extracellular vesicles are in really every fluid, not just blood and saliva. They're in every bodily fluid and secreted from every cell. So the interesting thing though about platelets is they capture all this information. They sense this information in our blood. So as they're circulating in our blood, they're actually taking in information. And we've known this for a long time when we think about taking in plasma proteins, but they're also taking in these messages, these small little extracellular vesicular messages. And this is just fascinating because these are, I always think of these little messages like drones, and that kind of gives you a visual of how powerful and important these are. This is kind of a background to what we think in our lab about platelets and the platelet release rate. And a number of years ago, then we hypothesized that, and this was based on not just our work, a number of emerging papers that were coming out from lots of different people in the field. This idea that platelets, as they're circulating in our blood, and also as they're born in the bone marrow and now also in the lungs, as they're circulating around, they're picking up information, and they're almost like they're educated by their environment. And so we hypothesized a number of years ago that if we took the platelet release rate from 100 different people, that we could start to see the signals of health and disease. And that's what we did. So that's what I want to tell you about today. So we used our platform, which we've named Paladin platform. So Paladin stands for platelet-based diagnostics. And this, we believe, really reinvents how to find diagnostics in the blood, and meaningful diagnostics at that. So we started, I don't know how to go back. I don't know how to go back 2 slides. Sorry. Please, thank you. Yeah, thank you, sorry. So this platform takes platelets, activates them in vitro, activates them, takes out, we're good at separating, biochemically separating out platelet release rate and doing it well. And then we take that platelet release rate and we subject it to lysis to break open all the vesicles, and then we digest it and put it onto mass spectrometry, and then use a variety of different data analytics techniques to find out the differences that are in there. This is what we did, and we did this is our 100 prep project. We did this for 100 different people, and I want to tell you a little bit about that today. So again, I've clicked on it twice. I'm really sorry. So sorry about this. I don't know how to go back. Thank you. So what we did first was we wanted, I suppose, to show a proof of principle. And so what we did was we took 32 healthy people of different ages, of different sexes, 32 healthy people, and we wanted to look to show that their platelet release rate looked the same. And wonderfully, it did. And we published this in 2018. And I hope you agree. Each one of these bars here, I don't know if you can see it very well, it's kind of small, but each one of these bars here represents an individual person. And if you look across, and each of the lines then is each of the proteins in that release rate. And you can see that there's very little variance between these 32 healthy people when you look at their platelet release. And this is published in Proteomics in 2018. Really interesting thing is when you look across the 32 and look across the 32 all the proteins that are seen in every single one of them, there's incredibly little variance. It's the variance, the coefficient of variance for this biofluid, if you like, is 3.6% the average. So this was wonderful to show that we could see this in healthy people. It looked the same. That was our first proof of principle. Our second proof of principle was that we wanted to show in a physiologic condition that the platelet release rate could be different. And so we did this in pregnancy. So Fionnuala, my colleague, she works in 2 hospitals, as I said, and one of those is a maternity hospital, one of the largest maternity hospitals and busiest maternity hospitals in Ireland. So we had access into then the blood of healthy pregnant women. So we took the platelet release rate of 18 healthy pregnant women and compared it against non-pregnant women of similar age. And what was really nice is you can see that these look different. Okay? So I hope you can see that these look different. Well, we published this in 2019. And also, when you did principal component analysis on the differences, you can completely separate out the different groups. So that was our first proof of principle, was in healthy patients. Our second proof of principle was in pregnancy, and that accounts for 50 of our 100 PrEP project. And then for the other 50 of the 100 PrEP project, we wanted to look at different diseases. And we're very interested, obviously, as a platelet biologist, and then as Fionnuala as a hematologist that's very interested in thrombosis, we wanted to pick disorders that had an inflammation and thrombotic underlying disorder. So the first one I wanted to talk about was, okay, I can't get that to move. Oh yeah, so the first disorder is that we looked at is one of pregnancy, and this really is a devastating disease. It's preeclamptic toxemia or preeclampsia or PET. It affects 1 in every 10 pregnancies, and really it's the huge numbers associated with it. Annually, this causes 50,000 women and 500,000 babies to die each year, and an additional 5 million babies are born prematurely because of PET. And right now, there is no screening test for this disorder. And the only cure, and that's why there's so many preterm babies, the only cure is delivery of the baby. And really, it's a balance between the mother's life and the baby's life, the mother's health and the baby's health, really. And so the challenge, really, the big challenge here is to develop an accurate risk stratification tool for preeclampsia. So that's what we wanted to do. And so then we basically took our Paladin platform, we subjected women with preeclampsia to our Paladin platform, found differences. And not only could we find differences between healthy pregnant and women with preeclampsia of similar gestation, but we also, of those women, and we had 32 women with preeclampsia. Of those women with preeclampsia, we could split them in between women who were going to remain stable with preeclampsia and women who actually progressed to severe preeclampsia. So we feel like we had, not only had we found biomarkers to diagnose preeclampsia, but we actually found markers to prognose and to risk stratify the women who were diagnosed with preeclampsia as to their outcome, whether it be moderate or severe. So these diagnostics, and why you haven't heard about them before, is that these diagnostics are actually, we've submitted the patent on these, and right now we're in the middle of proving that this works, this diagnostic tool works, or risk stratification tool works. So right now we have collected the blood of over 156 pregnant women from all around Dublin, and we are hoping to take it national, but I'll talk to you now about this. So the interesting thing as well is, and this is something from me from a platelet perspective, is that once you know what to look for in the blood, because a lot of these underlying thrombotic disorders have a level of platelet activation. So platelets are you've got a lot of circulating activated platelets in these diseases. And, there's lots of evidence in the literature that platelet factor, you can pick up in the plasma, platelet factor 4 or thrombosbondin. So what we said is it's like a needle in the haystack almost. You know, if you know what to look for in the plasma, then you can find it. So that's we've proven this now, that once you know what the differences is using the platelet releasase, you can actually find that difference in plasma, know what to look for. And we were going to look for that difference by mass spectrometry, but now we've actually developed ELISA-based kits or antibody-based tests to actually look at this. So where are we now with this project, AI Premi? We've actually, we're taking these patent pending markers that we can quantify by ELISA, and we're actually using machine learning, and we're working with a company called SATS Institute, which is based in North Carolina in the US, but they have they're a worldwide company, and we're working with their Irish office to actually integrate the diagnostic information together with patient history, the blood, the booking bloods, the bloods from the time that we take the sample, and just clinician assessment knowledge as well. We're taking data from multiple sources and integrate data using machine learning, and the platform that we're using is a SaaS bio platform, which we use in a cloud-based system called, and the cloud we're using, just in case anybody's interested, is Microsoft Azure. So what this is showing you is that actually we looked at, we had to do this because we looked at our biomarkers with I suppose regular statistics, if you call it that, and it actually didn't see any patterns. So we needed to actually bring information, because remember, preeclampsia is such a complicated disorder. We had to bring information in from multiple sources to actually start to see a pattern. And we're absolutely delighted now, because our area under the ROC curve now is 0.834. So we're really excited, and we're next step really is to bring this across Ireland. And we've just applied for funding to do this, to bring this test all across Ireland, and hopefully have a test for preeclampsia, and then obviously across Ireland, and then hopefully across the world. So I've just noticed we've got 2 minutes left, so I'll just talk very briefly about this. But if anybody's interested, please send in some questions. I can answer them. So platelets are involved in many different disorders, as I said at the start, and one in particular is interesting to us in Ireland because we've got a really high incidence of multiple sclerosis in Ireland. And there was a paper from Meinrad Gauss's group by Harold Langer in 2012 showing that platelets were even found post-mortem in the lesions of people who suffered from MS. And they did some work in animal models of MS and showed that when you knock out the platelets, that it actually is better for the disease. So we also then looked at the platelet releasase in multiple sclerosis, and we compared two different types of multiple sclerosis. I'm not going to go into it now, but two types of multiple sclerosis, like an inflammatory one, and one then, as the clinicians described to me, as almost the inflammation was over. And we actually looked at the platelet releasase. Now, this is just, I haven't showed you a lot of this data, but this is looking at the small vesicles, these exosomes in the platelet releasase. And you can see immediately that there's an absolute difference in the amount of these between, say, healthy people, age-matched healthy people, and people who have inflammatory multiple sclerosis. There is a decrease in the amount of these extracellular vesicles. And we do think that, there's a paper really interesting that was published in 2018 in PNAS that shows that platelets recirculate after degranulation, and there's a level of activation already in these MS patients. The interesting thing is there's been a lot of studies done in huge populations of MS showing that they may have a thrombotic underlying disorder as well. So just in the interest of time, I just wanted to also talk to you about, just if you're interested, I don't know, sorry, I keep clicking on the, if you go back a slide, apologies. So this actually just came out this week, just this week. It's an analysis of our group looking at platelets in COVID-19. If you're interested, we compared hospitalized patients with COVID-19 who were on a ward and ones in comparison to people in ICU. And the really interesting thing for me was the level of the release of the cargo from these patients. What we saw was very low doses of agonists like ADP, a low dose of an ADP agonist, U46619. You actually got, they were just so sensitive. They just reacted so quickly. You got 30 to 90 fold, depending on the severity of COVID, higher activation threshold and higher release of their dense granules. This was really interesting, and it just shows that this is the level of these hypersensitive platelets and hyperactive platelets circulating in the blood of COVID-19 patients. Yeah, so also just to highlight, you may be interested that we've also looked at the platelet release rate in coronary artery disease. This was with Minor Gauss's group in Tübingen. And the interesting thing was that when you look, this is just looking at circulating levels of these small extracellular vesicles, either in the platelets, in the release rate from platelets, or circulating in plasma. And the really intriguing thing was post-STEMI, you get a massive decrease well, it's not significant in the platelet release rate, but it is significant in plasma. There's a decrease in the amount of circulating small extracellular vesicles. This was quite surprising because you always see the opposite in the large extracellular vesicles, and we did have that issue on review, but actually there's a paper just last week come out that actually agrees with us, that shows after a STEMI, there's actually a lowering of the circulating small extracellular vesicles. And then lastly, oh, sorry, I've done it one more time. I've done it. I'm sorry. Lastly, this might be also of interest. This is currently under consideration, and it's looking at comparing rivaroxaban therapy with warfarin therapy in atrial fibrillation. So again, this is looking at plasma samples and looking at the small extracellular vesicles in plasma. So the extracellular vesicles between 30 and 150 nanometers, so tiny. Remember, I said you could fit 1,000 across a human hair, and you can see a massive pharmacological effect of these patients that have been treated with 2 different drugs. So any questions, please send them in and I'll answer them. And obviously, I am just the face of this group today, and thank you so much for the opportunity to present. But this is the rest of the group. Fanula here, unfortunately Barry is not pictured here. Unfortunately, we are in level 5 lockdown in Ireland, and we cannot take pictures and get us all together to take pictures. And this is then the AI Primi team that's come together of the project I spoke to you about, preeclampsia, and we're working with all 3 Dublin maternity hospitals and with the SAPS Institute. And I'd like to thank you for your attention and look forward to the questions, and very much look forward to Dr. Skeet's talk. Thank you very much.
Thank you very much. That was fantastic, a really good presentation of the work that you're doing. There are a number of questions for you in the Q&A. If you'd like to answer them during the talks or during Dr. Skeet's talk, you're welcome to, but it would be nice if we could, if you could address them for the group at the very end. So I'm going to introduce Dr. Leslie Skeet now. So Dr. Skeet is an assistant professor and hematologist at the University of Calgary. Her clinical and research focus is on venous thromboembolism and women's health. She is the principal investigator of the pilot study PARTM, which stands for postpartum aspirin to reduce thromboembolism, undue morbidity. And this trial will evaluate the feasibility of low-dose aspirin for postpartum women with VTE risk factors, and it's a placebo-controlled study. Her presentation is on postpartum thromboprophylaxis, the rationale for the pilot PARTM study. So welcome and thank you very much, Dr.
Thank you for having me. I look forward to presenting some background about postpartum prophylaxis, as well as more information and where we're at from the PARTM trial. I'm just advancing the slides. Okay, perfect. Thank you. Here are my disclosures. Our pilot partum trial is funded both by CIHR as well as Invent for our international subsites. And one of the residents, obstetric residents in Calgary, Lauren Andrew, is leading a qualitative sub-study that's funded by both CanVector and recently the Foundation for Women and Girls with Blood Disorders. So I'll just start with a very controversial quote from a controversial obstetrician in the Northwest Territories, where in one of his opinion pieces stated that women with common VTE risk factors should be offered low molecular weight Hep prophylaxis only as part of a randomized controlled trial. And I think that's a pretty extreme and controversial statement, as this is something that we do routinely in many centers. So I'll talk a little bit about how we got to that statement and where we're at now and where we're going with information about the partum trial. So we know that VTE or venous thromboembolism, deep vein thrombosis, and pulmonary embolism, there's an increased risk during pregnancy and postpartum, while the risk is generally the same in the antepartum and postpartum time. Because of the shorter postpartum period, the per day risk of thrombosis is highest in this early postpartum time. The challenge is that in the general obstetric population, while this risk is higher, the absolute numbers are still quite low, that in the postpartum time, 4 to 8 per 10,000 deliveries will be complicated by a thrombosis. So it is really hard to study. This is very uncommon. But on the opposite side, these are also and can be very important events for patient, making it quite a challenge. Our CanVector patient partner wrote a beautiful letter to accompany our CIHR grant and highlighted that these numbers may be statistically low, but if there's one thing that I've learned from my own experiences with VTE is that statistics don't matter when it happens to you or your loved one. It makes research challenging, and it's trying to reconcile these differences in something that's rare but important for patients. Other considerations of low molecular weight heparin can include the balance of bleeding, probably low, but varying in different studies, skin reactions, and quoting up to 29% in some studies, and some concern from wound complications and hematomas, although the definitions can be quite variable, and even adjudication of these events can be quite challenging. So instead of looking at the general obstetric population, can we start to identify a more at-risk population for a targeted intervention for thromboprophylaxis postpartum? Putting the kind of clinical trial hat on when we look at confidence in trial results, our goal is, this is an equation from David Sackett's book, and really, can we increase the signal while decreasing the noise, trying to select out those that matter who are at risk of having thrombosis, while decreasing those that are less of a risk. We know that patients who've had prior VTE are clearly at risk, even based on some small numbers of observational studies. In a retrospective review of over 1,000 patients, 120 did not receive postpartum prophylaxis, even with a past VTE. And that recurrence rate is around 8%, upper bound up to 14.6%. And I think the majority of people would feel uncomfortable, rightly so, not having on any prophylaxis. Some of the postpartum risk numbers, whether it's an unprovoked estrogen associated or provoked clot do differ, but all are in the range of our usual thresholds to provide postpartum thromboprophylaxis with low molecular weight heparin. I think the challenging group, and that maybe at-risk group that to look into further, are those with transient risk factors that are primarily reported in case control studies. So risk factors of bed rest during pregnancy, elevated BMI, preeclampsia, postpartum infection. You can see this longer list. So far, they've been really focused on that kind of relative risk in compared to a control group, that we don't have those absolute numbers or percentages. There's also a major assumption in the guidelines that these risk factors add up and are additive in risk. The SOGC guidelines, for example, is when multiple risk factors are estimated to be greater than 1%, and it's kind of any 2 or more risk factors and then the longer list. But I don't know if we actually know this. By adding up these individual risk factors, we get to a certain a target. There's a lot of assumptions. As an example, if you had a patient with antepartum bed rest and pretty strict bed rest for 1 week or more during pregnancy and an elevated pre-pregnancy BMI, on their own, the adjusted odds ratios are 10 to 11, kind of 2. But when it's in combination, it's more than additive risk. So maybe there's certain interactions that we're still learning about, and how we adjust or apply for that, we really still don't know. And what this means for that absolute risk percentage is still unclear. We can see that discrepancies and this variation as part of the guidelines, the 2014 SOGC guidelines, the more recent 2018 ASH guidelines, ACCP, and the RCOG guidelines. There are some trends where the more potent thrombophilias recommending postpartum prophylaxis, more mild thrombophilias like heterozygous factor V Leiden or prothrombin gene mutation, likely not. But even then, there's this differences and variation in guidelines despite the same data that we have. And why is that discrepancy? Some of you have maybe have seen these charts. It took a while for me to make these charts, so I'm using them in more than once. As an example, if you had a patient with factor V Leiden, looking at their antepartum and postpartum risk with or without a family history, this is taken from the ASH meta-analysis data compared to protein C deficiency, there are some differences. Those risk estimates are imprecise. You have your point estimate, but that there is a wider confidence intervals, especially in those rare, more rare deficiencies like protein C deficiency. The spread or the upper bound confidence interval goes a lot higher when we're more uncertain about this data. So there are differences. What do you judge your recommendation by? Is it the point estimate? Is it the upper bound confidence interval? And these absolute numbers are calculated from the relative risk. So there's some assumptions, and these calculations are imprecise. An example of 2 meta-analyses that were published in the same year using different methods for the systematic reviews gave different answers. So the same studies that went into each of the meta-analyses gave slightly different, or sometimes largely different answers in absolute risk. For example, protein C deficiency postpartum, a difference between 1% versus 5% really just highlights the limited data that we have to go into these models. And then lastly, the arbitrary thresholds that we make our decision, make our cut points differ depending on the guideline, the committee, are we choosing a 1% threshold, which was most recent from the ASH guidelines postpartum, similar to SOGC? Is it 2%? Is it 3% to draw the line in the sand for when we would give thromboprophylaxis? I think kind of some fair statements is that those with a less than 1% VTE risk, if you had a cesarean delivery alone, especially a lower risk if it's elective C-section, and most of those single transient risk factors compared to those who had prior VTE, probably the potent thrombophilias, and probably those sick patients who have cancer, trauma, ICU, although we don't have that data. We kind of have these two big groups. But then there's everything else in between, and that's what we're trying to study and get more information on. Surprisingly, or maybe not so surprisingly, that the evidence for low molecular weight heparin is limited. We're talking about 5 up to 6 studies. The most had 646 participants in, some comparing different low molecular weight heparins, some compared to placebo, with different durations of low molecular weight heparin, with limited numbers. And through the work from Mark Roger and colleagues from the PROSPER studies, a feasibility trial looking at low molecular weight heparin for those at risk of VTE was not feasible. Women did not want to go home on and comfort level doing extended injections, and also the challenges of doing postpartum randomized controlled trials. But aspirin is effective. We're getting more data from EPCAT-2, EPCAT-3 is ongoing, looking at aspirin being non-inferior to other anticoagulation. So far, after a short lead-in, after hip and knee replacement surgery, which is a much higher risk group than the postpartum population. And that through breastfeeding, infant data, that we do have an acceptable safety profile of low-dose aspirin and is considered safe. So this is really all of this information driving the rationale for the PARTM trial, and really focusing on a pilot study with our focus is feasibility. It's a pilot run really based on PROSPER, based on the challenges of doing postpartum randomized trial. Can we randomize enough women to make a much larger monster trial of 50 to 70 centers, thousands and thousands of patients possible? And unlike earlier studies, including PROSPER, where we were doing screening ultrasounds and blood work, I got feedback from the CanVector community really to keep this as pragmatic and as simple as possible. So up to 48 hours postpartum, which is still a challenging, a tight window, women will be approached, screened and randomized to low-dose aspirin, 81 milligrams in Canada and 80 milligrams in Europe, versus a matching placebo, and that we leave them alone but are there available for questions with a phone call or visit at 6 weeks and a phone call at 90 days. So far, these have been phone calls in the era of COVID, and that even during pregnancy, we can start to talk with patients about PARTM, but a lot of the risk factors don't develop until later. So it is very heavily on the obstetrics and labor and delivery and postpartum ward. Our goal of recruitment, our minimum is a mean of 4 participants per month per center, with a target, and our internal target 8 per month per center, focusing on feasibility and running each site for 6 months. Here are the current sites led by myself and mentor Mark Roger. Calgary, we have been open. There are many other investigators, including our residents, Lauren Andrew, and to highlight that we have many Canadian and international sites, including Ireland. France is the first to cross the finish line for regulatory approvals, contracts, ethics committee applications, and then the rest of the sites are slowly we're onboarding and working on each of these applications. And to highlight that I'm a hematologist, Wei Shan Chan is in obstetric internal medicine, but the rest of our site leads are all obstetricians, and it's really that primary prophylaxis study on the postpartum ward and this patient population. I've learned a lot about obstetrics. And we have a patient partner team, Suzanne Dubois from CanVector and Anne-Marie O'Neill from the Invite Ireland team. Here's our inclusion criteria, where it's one of these risk factors of an inherited thrombophilia or strict bed rest, or two or more of the more modest risk factors. And our exclusion, more than 48 hours since delivery, received more than 2 doses of low molecular weight heparin, need for low molecular weight heparin or anticoagulation or aspirin as judged by the local investigator. We give examples, but really it's up to the local investigator and comfort level in enrolling in the PARTM study and keeping it very pragmatic. And some other safety information, including a most recent known hemoglobin of 70, known platelet count of 50, so no additional blood work or imaging is needed, just really trying to be as pragmatic as possible. Where are we at in Calgary? We've been open since October 7th. Just reflecting on the whether it was right or wrong, the decision to open, and then the second wave really came quite strongly in Alberta. But despite having our peak numbers of COVID in December and seeing those effects in January, we have been able to recruit throughout this COVID pandemic, despite the COVID pandemic. The January numbers are lower. We were not allowed to go to the wards for 2 weeks when there was one case and in a subsequent watch where no researchers go to the unit for the watch. But otherwise, we've been cautious and careful, and I'm learning a lot about how to run trials in this inpatient setting with COVID. And we are doing the parallel qualitative study. So far, we've interviewed 5 participants and 15, I think 16 today, trying to understand the facilitators' barriers of both people who were part of PARTM as well as those who have declined enrollment. Just to get a sense of how much work and what's happening every day is that we've screened almost 1,000 patients on the ward. We have a checklist system in Calgary where every chart will get a checklist that identifies these risk factors. They're approached by Circle of Care, and that we talk with them further. So, and it's high turnaround where every day people who've had a vaginal delivery are here for one night or one day. For cesarean delivery, it's 2 days. And so it is quite high turnaround and screening every day. We've had 18% or 175 eligible patients who've met our eligibility criteria. And of those, 23% or 40 have been enrolled so far. And different reasons for some declining, some not wanting us to approach or not approaching for other reasons. A small number that need for low molecular weight heparin, a larger number for those greater than 48 hours, but still not too bad, and a couple of other reasons for aspirin allergy or less than age 18. So looking at our set feasibility endpoints, an important part of pilot trials is that our minimum target of 4 patients per month we, at least in Calgary for Partum, it is starting to look like it is feasible. However, this is the highly motivated lead site where I'm next. I will go up to the postpartum ward, and we have this system and buy-in in place. What this looks like for the other sites, I think we still have to see what happens. But it does look like, compared to the Prosper study, which looked at low molecular weight heparin first for 21 days versus placebo, and then a second run of 10 days versus open label, our numbers so far have been higher for recruitment rate. Again, keeping in mind that it's just the lead site, and we need to have 7 other sites to really get a sense of feasibility around the world. And there's some information that will continue to collect. Our proportion of sites with greater than 18 months to contracts, we may not make that. It's been a tough time with COVID. So we're just doing our best to see how feasible this study is, to see if we would apply then to the much larger trial. And the goal really is to see if aspirin, which is simple, cost-effective, could change practice, could change lives around the world. But really, this is our first important step to prove feasibility. And with that, we can open it up for questions. Thanks for listening.
Thank you very much, Dr. Steve. And thank you, both of you. Those were really outstanding talks. And I think really, shows us sort of the challenges we still have in hemostasis and thrombosis, and understanding actually some very basic physiology, right? And I have to admit, when I first started in hematology, I thought I was going to be, working in platelets. I just thought, wow, these are amazing little particles, not even having a nucleus, and look what they can do. So anyways, we have a number of questions, and we have about 10 minutes left. So I think all of you could see the Q&As along the way. So I'll start with Professor McGuire. I kind of looked at the questions, and perhaps I could categorize them in a bit in terms of, the questions really center on, number one, in terms of a quantitative analysis. Are you able to distinguish mild, moderate, severe preeclampsia using your platform, number one? And then the other thing is in terms of timing, in terms whether the platelet release dates are going to differ in first, second, or third trimester. And are you able to actually even prognosticate, even before, at the time the patient becomes pregnant? So those two are kind of related. If you could address those, that would be fantastic. Thank you.
Yeah, so we have looked only in third trimester samples. That's what we've looked at. So actually the women that we studied in depth and took the platelet release, because you got to take a lot of blood. Well, not a lot of blood, but you got to take a lot more than just a plasma sample. You got to take about 40 mils of blood to actually analyze the platelet release properly. So we have looked only thus far in third trimester samples. These were women diagnosed with early onset preeclampsia between 26 and 32 weeks of gestation. We have access, believe it or not, into a first trimester biobank, and that is what we're going to do next. Yeah, so we want to look to see if these markers that we found in the third trimester, you can already see them in the first trimester. I can't answer that question now. Don't know, right? And then your other question was about differentiating between severe. Yes, that's actually so. So of these women that were recruited into our study that had early onset preeclampsia, some of them came in, so they were all diagnosed with early onset preeclampsia, and then some of them then, based on how they progressed, we took the blood when they were diagnosed, but then we found out their outcome. So we knew those who progressed to severe versus those who stayed moderate or stable. So we were able to differentiate between them, and that's really exciting for me as a basic scientist, to be able to hopefully be able to provide a risk stratification for clinicians, and give them more information when it's needed most, so that they can understand maybe when to deliver that baby, or also not deliver. This is the really key thing here is that, and I speak to a lot of obstetricians now. There's three senior obstetricians involved in this study, and they tell me, sometimes it's when not to deliver. Can we leave that baby in for another week of gestation, whereas suddenly they don't need to be in an incubator for a long time, and I think that's what's powerful for me, is that I can be able to help.
Wow, sorry, my audio seems to be kicking in and out. Thank you. That's great. I mean, again, just tremendous work in this area, and it's nice to see that we will be able to, start, starting to address some of these questions and really have an impact. Now, Dr. Skeeth, we have a question about VTE risk. So can you comment if the 10-fold higher relative risk to VTE in the postpartum period varies according to the age strata? So 15 to 20, 20 to 30, 30 to 40, over 40, if that differs. So I assume this is regarding the age groups for the moms. So this comes from one of our pediatricians. So I think actually a really great question, as we know that the risk of thrombosis varies according to age as well.
Yeah, we have a little bit of data, and I'm happy to send and look into it further and send you further information. Whenever we look at age as one of those risk factors, and for example, the Jacobson, the case control studies, when we look at age, it may be a modest risk factor for VTE. I'd have to go back and look at the absolute risk in those different categories. And some guidelines do use age as one of those risk factors. When we look at the adjusted odds ratio, it's not as strong, kind of 1.5 to maybe 2. I'd have to go back to see. So I wonder if there's other factors at play. And I don't know the question, age plus IVF, also a modest risk factor. But you wonder if, those older moms are more likely to go through IVF. Yeah, great question. Maybe that modest signal, but again, we don't have the great data.
Yeah, definitely we need more data in this area. And going back to Professor McGuire, so more sort of basic science question. So again, I'm just trying to pull some together. So number one, did you look at complements and specifically polyphosphate? And also, what are the major release dates uniquely found in preeclampsia? And if there are any correlation with biomarker predictors like SLT1, PLG?
Yeah, so we do see complements. They're high abundance proteins in the platelet release site. We don't measure polyphosphates. Like I said, there's other effectors in the release site, like RNA, like lipids, like polyphosphate. We aren't measuring them. I'm sure they're there and they may be changing, but we aren't measuring them. We're a proteomics lab, so our speciality is so we prepare the release site to look at proteins. In terms of you clicked in and out, but I heard the soluble FLT1 PLGF ratio. Yeah, so that is a rule out test for preeclampsia. We're hoping to be able to produce a rule in test for preeclampsia. Well, at least our hope is to give more knowledge and information to the clinician in real time. That's why we've moved to an antibody-based test. So we should be able to, once the clinician, this is with the with the bloods that they will order for a preeclampsia screening, they will order our test, and then they'll have more information back to them at the right time. That's what we're trying to do. It's not, I suppose, we can't say yet if we're specifically ruling in preeclampsia, but as we increase the amount of women in our study, we hope to be able to say that, but it's a bit early yet. I hope I answered everything there. There may have been a little part that I missed, but I didn't mean to. Apologies.
No, you covered. Wait, 1 more minute left. So I have a question for Leslie. So Dr. Skeeth, when you were showing, again in Calgary what you're doing, I think it's amazing you're able to carry this on during COVID. So we're all sort of feeling that COVID crunch in terms of the, how research has for the last few months for some of the study, but you're obviously enrolling, so that's fantastic. You have a number of patients who declined participation in your feasibility study right now. Are you planning to follow these patients by any chance in terms of a registry to look at their outcomes? And are these patients, are these women declining for any particular reason? Again, just to identify, is this a separate group? Because we're always, trying to ascertain, patients who don't participate in studies, are they somehow fundamentally different than others? Because we're always talking about external validity of our studies as well. So when I have a huge group that are excluded or self-select not to participate, I think there's increasing interest to understand who these people are and the results of findings.
Absolutely. We're trying in detail to try to capture why for every patient, why they aren't being included in our screening logs. But I think that's the beauty that a qualitative study could look into further. The big reasons so far have been the busy postpartum time, the idea of doing anything extra for some women as I could certainly imagine in taking a pill, kind of documenting it every day with a medication diary, the phone call follow-ups, especially for new moms, or there's a lot going on if a baby's in the NICU or something more. That is maybe one of the reasons. Taking medication postpartum is also a major reason that we're noticing. So taking anything extra, even if it's safe, and when we review the information, some people are not comfortable with. Less people, I think there's less information about the comfort and risk. It's a challenging group where some may not know that they have these VTE risk factors, whereas others have been told throughout their pregnancies that they're at higher risk if they have a thrombophilia. So even in the type of person and how to navigate that conversation, I think really depends. And so hopefully we'll gather some more information. Those are the big reasons, but there are others to see. But it's reassuring that some people are saying yes, and we'll also ask them and why they said yes to the study. We aren't doing any additional registry information. It's a really good thought to think about what else could we capture if they're not part of the randomized trial in this setting, but maybe in those, for example, who are already on anticoagulation, who've had past VTE. There's so much we can look and capture kind of in a cohort or maybe less of an intervention study. There's lots that we can do, absolutely. It's a really good point. Thank you.
Thank you, Dr. Steve. So it's 9:02 for me anyways, and certainly further along in the day for the rest of you. I want to thank everybody for participating. There were some great questions submitted, and again, two outstanding, fantastic presentations by Professor McGuire and Dr. Skeeth. Our next seminar will be in March. It's actually scheduled for March 24th, and we will send out the details as soon as we can sort of nail down the time. So thank you very much. Make sure that you complete the evaluations. You'll be receiving those through your emails, and this will allow you to claim your Royal College MOC credit. So again, thank you everybody. Have a great day and stay safe. Hopefully all of you will have had your vaccines already, if not in the next little while, and see you in a month. Bye-bye.
Thank you. Bye.
Bye. Thanks, everyone.
Bye. Thanks so much. Bye.